Okay, part two of our talk, more the interventional side of things, of what can we do in IR. Again, no disclosures. Review basics of arterial interventions, focused more on anatomy than the IR techniques, but we'll look at some interventions that we do, and again, focus on diagnostic imaging and guiding us to treat various disorders. Again, if anybody out there or in the virtual audience is studying the VAR study guide on the ABR, goes over what needs to be done for the interventions part of it. Angioplasty stents is what's listed, carotid stenting, pharmacothrombolysis, thrombectomy devices, which there are a number of these days, aortic endografts, emergency embolization, and elective embolization. So we talked a little bit about the diagnosis of those in the last talk. We'll focus a little bit more on the intervention side of that. So choices for arterial access, femoral artery, we talked about the anatomy and why that's so important in the last case, but why do we choose this site most commonly in the IR world? Well, number one, it's pretty easy to get to. It's over a compressible site, which is the femoral head. It's usually big enough to fit large sheaths in for EVARs, TVARs, pretty much anything you need to do. It's relatively free of atherosclerosis. Now, if you've worked at any VA, you know that's not true. It certainly can have some plaque in it, but relative to other arteries, it's usually still decent enough to get into. And then also, if you do cause a complication, it's a little less risky, right, to be dealing with a leg complication than somebody's hand. But coming more into favor is radial artery, particularly in the cardiac world and in the neuro world. Some people in body are advocates of this as well. Patients like it for obvious reasons, just resting their hand after a case, being able to sit upright instead of flat for 2 to 4 to 6 hours, depending on what your protocol is for femoral access. So people are using that more as an alternative, but you are limited in size. So you need at least a 3 millimeter vessel. You can't really go higher than a 5 or 6 French sheath in most cases. The brachial artery is a little bit bigger, but a bit more risky just because you're higher up the arm. And the biggest and most feared complication is a hematoma around the nerve sheath there, where you can end up with numbness, tingling, or even loss of motor function. So it's fallen out of favor pretty much unless that's the only vessel you can get into. So most people will go for the radial artery these days over a brachial. So femoral artery, I mentioned in the last talk, the anatomic boundaries, so the inguinal ligament, and then the inferior epigastric and deep circumflex artery, and then the profunda takeoff and the SFA. So really mid-femoral artery is the way to go. We talked about complications of a high stick in the last lecture, but going above the inguinal ligament or above these vessels, you can deal with a retroperitoneal bleed or a high stick. Is there a problem with going too low? Well, it's not the end of the world if you punctured here, and in some cases of revascularization, people will even puncture the SFA and go down the leg. It's more that this vessel is smaller, and if you have a sheath in here, you could be obstructing flow in a narrow vessel or a plaque-filled vessel to the entire leg. So that's why we try to go a bit higher up and into the femoral. And then I mentioned brachial artery access, where you end up with nerve issues is typically a high brachial access. So if the lower you go, there's less of a risk of that. And then we talked about radial access as being a more popular alternative. The right side is a bit more challenging, dealing with the arch as opposed to the left. And also most people are right-hand dominant, so we tend to go left-sided access. So the appropriate level of vessel entry, as I mentioned, is the mid-femoral head, so choice 3 is really the way to go for an exam purpose. And remember, in the patient, particularly if they're obese or have a lot of tissue in their thigh, you do have to go through all that tissue before hitting the artery, so your puncture is usually a bit lower than this since you're at an angle. So if you started with your needle here and went into the vessel, you could end up with too high of a stick. So mid-femoral head is the goal for access. We talked about this in the last talk, but which vessel forms the boundary between the external iliac and common femoral?